Everyone, thank you for attending today's session. Today's session is going to be on outbreak management and environmental affecting within our community support services agencies. What I'm going to start off by doing today, we're going to start off on the outbreak management and workers' health and safety for community support services and mental health and addiction. It's something that I had presentation I had prepared for our sector a few months ago. So this presentation is going to be primarily based on community support services agencies, ADP, mental health and addiction facilities as well, and how we handle outbreaks. I'm going to be upfront right now. 9 times out of 10, we may not be handled. When I say handled by public health during outbreaks, be it respiratory, gastrointestinal. These health units tend to resource or hold their resources for long-term care homes, hospitals, retirement homes, and congregate living settings. However, based on the nature of what has occurred during the pandemic, and also depending on the health unit that you are within, your facility is within, you may get public health that may reach out to you. If you do monitor what happens in your facility, you do report it to the health unit as well. So I do know that there are some health units out there that still respond or still monitor what's happening in the community. So again, I'd like to welcome you to the Outbreak Management and Workers' Health and Safety presentation. Today's presentation at first is going to be on outbreak case definitions, which we're going to hit on a little bit on when do we call outbreaks and what types of case definitions do we use. We're going to go through outbreak identification and line lists, how to properly fill those out. Those are very critical whenever we're dealing with outbreaks. For public health, it's the holy grail and understanding what's happening within that facility. We're going to talk about also the roles of public health. What is it that public health does? What do we do? How do we respond? What is it that you have to have for them? We'll talk about the role of the employer. What is it that you have to do? What is it that you have to have captured as well? Or what is it that you have to monitor within your facilities or agencies or organizations? We're going to talk about employer workplace measures, employee support, case management, contact tracing, just a bit, infection prevention and mandatory reporting. Some of these things have changed, which I've noted in the presentation as well, but we're still going to touch upon these things. We're talking about case management, contact tracing, which we won't get into in-depthly, and that public health are the ones that provide the in-depth contact tracing. They are the ones that would contact anyone that is positive with a reportable disease to determine who's their close contacts and to determine who would have to be isolated. And we're not just talking about COVID-19, we're talking about influenza A as well, and any other type of outbreak that we may have to deal with in the coming months as we get ready for outbreak season. Workers' health and safety as well. So we're going to talk a little bit about those. The good thing about today is I do not have, I think there's one, but I don't have any videos. Last week I was having some issues with videos and it just made everything very choppy. So today is just straight presentations or slide decks. And just for everyone's knowledge as well, when I finish today's presentation or session, you will get a copy of today's slide decks that you can use within your organizations as well for training if you need be. So without further ado, we will begin. So outbreak case definitions. This is what we use to determine, is it really is this person really sick? Do they really have what we think they have? Are they a part of the group of other people that we may have ill within our facility, within our workplace as well? So case definitions, the purpose of case definitions is to ensure that cases are counted in a systemic manner. We want to make sure that everything's consistent, and we're able to compare and analyze all the trends. With a case definition, we're able to say, these people are line listed, these people are ill, these people are part of our outbreak. So it helps us as public health investigators, such as myself in the past, to develop something called an epi curve that we can establish what actually is going on in your facility or organization if you were an outbreak. In outbreak investigations, case definitions are used for counting outbreak cases only. They're not used for establishing clinical diagnosis or making healthcare decisions for an individual patient. So on those line lists, or as per a case definition, when you're establishing this case definition, we don't use this case definition to decide, okay, was this person clinically severe? Can we diagnose what this person has? It's just an overview assessment that, hey, this person has respiratory symptoms that this person normally doesn't have, so it's unexplained. We have a group of other people that have the same symptoms, so it just establishes that this group or there's a trend that's occurring within your organization or facility. Case definitions also build for an outbreak. It's often helpful to consider what is known about the outbreak, so it helps us decide, for example, what diseases or pathogens we're dealing with, descriptive epidemiology of ill persons, and how ill persons are likely to be identified. So testing practices and surveillance and systems as well can be used for this. So again, case definitions really establish whether these people or persons that are ill are part of this outbreak. I've been in many outbreaks where we've established multiple case definitions because we're dealing with multiple outbreaks, gastrointestinal and respiratory, be it influenza A outbreak, influenza B outbreak, and salmonellosis outbreak or Shigella outbreak as well. So an outbreak exists when two or more, and I'm just giving you an example of a case definition. This isn't how the case definition is established now anymore, but it used to be part of a case definition. But just give you an idea, an outbreak would be considered, or a case definition for an outbreak would be an example of two or more laboratory confirmed COVID-19 or influenza A cases with an epidemiologically link in the facility, so same work area, same shift, within either a 14 or 8-day period, depending on the organism that we're dealing with, where both cases will be reasonably acquired their infections in the same area or space. So examples of reasonable would be acquiring infection in your facility or at work where they all have a known exposure. And these are how our case definitions are established for outbreaks. They do change, and depending on organism or disease that we're using, there's already pre-designed case definitions that are established. Like for COVID, at one time it was two more, then it went to one person. These case definitions sometimes are not sometimes, but are established by the ministry. Public health uses it as a baseline for establishing a case definition for the community, and this is what we use to decide whether or not a organization or agency, a facility is under outbreak as well. So outbreak identification and line lists. Again, as I talked about this whole case definition and establishing a well thought out case definition that encompasses or groups those that are ill on our line list. Our line list now has to be made once that case definition has been established. And again, as I said, a line list is something that we use or that public health would use if a facility has a unexpected increased number of maybe ill clients or ill staff members, ill residents, depending on the agency or healthcare sector that you're in. The line list would have to be established based on those case definitions. And this is how we establish something called an epi curve to have a visual of what is occurring within that facility as well. So potential outbreaks may be identified through various means, such as identification of the case or cases associated with the workplace, complaints of illness at a workplace from employees, requests for assistance from an employer, information received from the Ministry of Labor. So Ministry of Labor is like, hey, we've been getting quite a few calls from occupational health, from your facility. This is probably a 10th call this week. This person has not been tested, or it has been tested, and the last 5 that you guys have tested were positive for X, Y, and Z. I think you have an outbreak. And in many cases like that, public health is going to be notified by ministry or from government agencies, and will probably respond anyways. Or a notification, as it says here, through other ministries, provincial or federal partners as well. So a lot of times this is how we establish something's going on in a facility. We have an increased number of ill staff members, residents, or clients. A case definition has been developed, so we know who's a part of this case definition. We established a line list, and now we're like, okay, you know what? Let's see what's going on in our facility. So again, depending on the organization that you are, some organizations who are congregate living settings have the ability now to have those staff or those residents or those clients tested, and then we can determine what it is that we're dealing with at the end of the day as well. So what is a line list? keep on talking about line list. Line list is a table that contains important information about each case in an outbreak. Each row represents a case. Each column represents a key variable such as a name, a date of birth, age, in some cases, depending where you are, if you're in a congregate living setting, a room, symptoms, onset date, and resolve dates. Now, if we are an ADP program, community support services, it's a little different. More than likely, you're not going to run into this situation where you're going to have an outbreak. If you do have an unusual amount of clients that are ill and you report to public health, they may want you to establish a line list so they can see what's going on, so they can visually see what's going on. Whether or not they will respond is all up to the health unit that you're in as well. So let's get back to these line lists. The line lists help to keep track of each case during an outbreak in an organized and systemic order, and helps to track sick staff, clients, or residents, which enable us to implement and control outbreaks effectively and efficiently. So by those line lists, I could see, okay, and use an example as a CLS, a congregate living setting. We have someone in room 101, 102, maybe 105 that are ill. They're all in one section. They have similar symptoms. They have similar dates of onsets. Some onset dates are slightly different than others. We're able to use these line lists as a visual aid to help us determine, okay, we can connect the dots with these two with staff. We can connect the dots with these two in terms of their proximity to each other, and they do talk to one another. These line lists help to pull that out and help us to put together or formulate a picture of what's going on within an organization. So when someone does respond, there's a proper response and proper control measures can be implemented as well. So it also helps to formulate an epi curve, which I mentioned early on, and helps the local health units to establish or have a better understanding of outbreak spread as well. So with those line lists, as much as you're creating them and you're adding names to them, if the outbreak's getting worse, again, we can say, okay, numbers are getting higher. Something needs to be done. The control measures that we've implemented aren't working. Maybe we'll stop doing this and do this instead. Or maybe, you know what, we're just going to shut down the unit because we can't get a control of this spread of this outbreak and things are getting out of hand. So again, as I mentioned already, it's a way of formulating a visual understanding what's going on in that facility during this period, which we consider as being the outbreak. Again, line lists have to be legible and concise. So if anyone here ever gets in that situation, well, hey, Dale, you know what? I'm in an outbreak. When we see the line list, we like them to be very legible and concise. It makes it easier for us to read and understand what's going on. Client or case name should be on list once, unless it's reinfection. A lot of times we do these line lists, you see the name twice, and like, well, why the name on there twice? Well, the person got better and then they started experiencing a cough again. I'm like, listen, once that person's on that line list, they stay on that line list. If they've recovered fully and they're out of isolation and they're no longer line listed, their names are still there. It just shows that they're resolved. Only time we'll put them back on that line list if they get reinfected and symptomology or new symptoms start over on that person as well. Should contain all required information, should be discussed and sent to your local health unit daily with updates, should only contain the names of those who are confirmed cases and meet case definition unless otherwise advised by your public health unit or representative. The line list must be updated daily and as needed to ensure up-to-date information is captured, and staff using the line list should be trained on how to use the line list correctly to ensure information noted is useful and correct. So again, this is kind of like that holy grail. This is what we need to see if you're ever in a situation where you're in an outbreak. I have an example here, and it's funny enough, the original one to this that was done in Toronto, I helped create it, and I think Durham used it, but it looks exactly as like the line list I had created many decades ago. I think I mentioned that at one of our last meetings as well. So this is from Durham. Very straightforward line list. I love it. I'm going to be biased because I helped do this one in Toronto. Has an institution name, has an outbreak number if you're given one, tells you whether or not this is for staff or for residents. Nice and easy. Along the side, case number 1, 2, 3, 4, 5 with a running tally, name and location of the facility. So if this is, again, I'm going to use a CLS for this first example. If it's in a facility, we got to put the name of the person, the location, what room they're in, 105, and the floor as well. Then we're going to include all the other information to the right, their gender, their age, big one, their onset date. When did these symptoms start? And what kind of symptoms do they have as well? Is there any complications? Now, in terms of specimen collection, this is also based on whether or not you're a CLS or a ADP program. Because if you're an ADP program, more than likely you're not going to run into this situation where you're going to have to collect specimens. You're going to have people coming to you who may have already been ill, and then they're going home. You may want to document that so you know something's going on. Or hypothetically speaking, someone's coming to your facility. They were ill or they became ill in your facility. We document who they've been around, some form of contact tracing, and then if later on down the road, hey, Dale, we're seeing an influx of numbers of new ill people, then we write those names down as well. Going into the whole process of having to submit specimens, that is not up to us. It's up to the client in that setting, and that would have to be discussed with the family member at the end of the day. For those of us who are CLSs or along the lines of a long-term care home or retirement home, you're going to have the ability to collect specimens. You're going to have the ability to do, and what I like to do is do a rat test from the onset of any illness, just to verify and rule out COVID, and then also take the PCR testing, other swabs to test, which we consider as multiplexed, to determine whether or not we're doing RSV, rhino, influenza A, influenza B, all the funny stuff that's out there right now in the community. And then we add whether a person is taking prophylaxis, treatment, and the status. Did they resolve? I knew some of the most. I remember I did provide a better updated line list somewhere recently over the last few weeks, and that had whether or not the person has died. Did this person pass on? Yes or no? Was a coroner called? Yes or no? And again, those are things that you would address if you're in a congregate living setting. ADPs are a little bit different in that regard. Roles of public health. We have an influx of new cases of list that's been established. We've called public health. Public health said, we may get involved. We're not too sure whether or not they are going to get involved. What do I do, and what's the role of public health? So the role of public health is to receive and investigate reports of cases and contacts of any reportable disease. Call public health, report. I'm going to mention something new again here, a baseline. So I always say to people, in any given day, you're going to have one, maybe two people. If you're a facility like a CLS where you're somewhat controlled, you're going to have a day where you're going to have one or two people that are just going to be sick at all times. So there's going to be some form of a baseline. So Dale, I have a baseline of about one or two, but I also not just have 5 or 6 or 7 people just reported illness over the last day or two. I'm monitoring them. Symptoms seem to get worse. What's happening? Report that to public health. And public health is either going to do one or two things depending on where you are located, what health unit you're in, depending on what type of facility you are. They're going to send out someone else to go and do the investigation. So that means is they're either one or two. They're going to come and visit you at your facility and do an in-person outbreak management team meeting, and then review the facility to see what you've been doing and ensure that things are being maintained, people are being isolated properly. Or number two, they're just going to talk to you over the phone to determine that everything's been put into place, because they're like, listen, we're really hectic right now. You're considered low risk. As long as those control measures are in place, we're good to go. If things get out of hand, give us a shout. We'll handle it from there. So public health, again, is there to help implement the control measures and guidance for outbreak control measures, or IPAC control measures. Sorry, IPAC control measures during outbreaks within your facility. That is their main objective: is to provide support and to provide guidance during those times. They also do issuance of orders by the medical officer of health. So, hey, things are getting out of hand. I have a few people that I think I need to take prophylaxis. They're not complying. Maybe the medical officer of health may have to get involved sometimes as well. They make recommendations on facility and outbreak testing. Who do we test? Who we're not testing? They provide investigations or outbreak numbers to coordinating and testing. They refer and or communicate with relevant stakeholders and ministries as necessary. And then they provide information to your employers regarding duty to report, still to deal with occupational health. They'll also deal with the Ministry of Health Ministry of Labor as well. They'll also may share some of these recommendations, orders with other government agencies and make them aware of what's going on. And sometimes public health will coordinate with occupational health, OHSA, and conduct on-site investigations as part of the outbreak investigation. So I always tell people, if you're an outbreak, don't be afraid. Public health isn't there to ticket you or take you to court or close you or embarrass you or hit you up with a fine. During an outbreak, we're primarily there to help support you with informational resources and to guide you during the outbreak as well, to help things move a little smoother. And the reason I say that, I was always on the other end as a public health investigator. I've walked into many places where, they're shivering, like, oh my gosh, please don't ticket us. I'm like, I'm not here for that. We're here to support you to ensure that the outbreak moves smoothly. People who are supposed to be notified are notified. Whatever signs that need to be posted at your front doors to notify everyone that you're an outbreak is posted, and to help you with the process of going through this outbreak, ensuring housekeeping is cleaning and disinfecting properly. Staff are monitoring the clients properly. Those are put under additional precautions. If we're dealing with a CLS, are put on additional precautions properly. PPEs that are being worn correctly, donned and doffed correctly, hand hygiene. All that is what public health would do if you run into an outbreak. That is their main objective. What shall the employer do? So, as the employer, you're there to support your employees with reportable disease illness information. Person has an issue. We have an influx of new cases. Public health gets involved. Public health is more than likely going to be coordinating with the employer, sending information to you that you would disseminate to the staff regarding what disease or what it is that we're looking at, and ways of preventing yourself from getting it. And if you do get it, where to get and seek help as well. They know and communicate the rights and responsibilities of the employer and employees, and sure you have policies that support employees who need to be absent from work due to illness or being a close contact of a person with symptoms of an acute reportable disease or confirmed infection. They're also there to ensure all employees are aware of the income replacement and workplace-related benefits they're entitled to if they have to be isolated due to symptoms of acute infections. So this is not just primarily due to COVID. This could be due to other things as well, depending on what you have or what kind of infection you have. Sometimes you can get external supports as well for employees. Employees are also responsible to report illness to their employer if it's likely to cause illness to another person in the workplace. So as an employee, you have an internal or a organizational responsibility to report any form of illness that you may have to your employer, so that they know what type of information to disseminate out to the rest of the employees or the workplace, or they can put specific and detailed control measures to prevent anyone else from getting what you may have. Many years ago, when I was working in Toronto, we had a outbreak at the Toronto Stock Exchange, which was very political, and it was measles, and it was just a bit of a mess. And again, the biggest thing with that was communication of correct information to the employees and implementing control measures. So there were certain members that were part of the outbreak who weren't allowed to return to work, and we had one person who tried, and because information was already disseminated to the employer, they knew he was not supposed to be there. He was sent home. These are some of the things that we do, or that public health will do, or that the employer should be doing whenever we're dealing with an outbreak, an internal outbreak within a facility or organization. If an employee discloses to you that they have been diagnosed with a reportable disease or have been exposed to a person with a reportable disease, confirm that they are self-isolating. So again, as I said, public health will organize, control the outbreak. We'll be speaking to the employer, and we'll ensure that whoever is supposed to be self-isolating, and we're not just dealing with COVID here, it happens with many other reportable diseases that are part of the reportable diseases list. They are isolated based on the organism or the infection that they have, and that they are staying home, and that the employer knows that they are to stay home between specific dates as well. So a lot of this is organized between public health and the employer at all times. Employer and workplaces also are there to clean and disinfect surfaces that may have been touched by an employee who was sick as soon as possible. Employees should not return to work until after the required self-isolation period. So, not just COVID we're dealing with here. If we were dealing with influenza A, usually isolated for 5 days. So it does change based on the organism and based on that organism's period of communicability as well. Individuals with COVID must self-isolate until symptoms are resolved. So, I left this in here because there has been a change to the return to work policy as well. So employers are supposed to be updated or should stay updated with any changes that there may be in terms of return to work policies or return to work recommendations from the ministry as well. Individuals who have been identified as a close contact will be provided with isolation instructions from public health based on a reportable disease, and use a staff screen question to determine when it's safe to return to work. So these are some of the things that we ask some of the employers to do to ensure a safe return to work as well. Sorry, it's a little small. I apologize, but I'm just going to go through this, not verbatim, but discuss this screen. Some of the other roles as well is to take steps in workplace outbreak employee support employees who've had to be absent from work due to illness, maintain their confidentiality, work with local health units to develop a list of employees, provide health unit with accurate shift records, follow public health guidance for implement infection prevention and control measures to control and limit further transmission in the workplace. You also must let workers know if you've been exposed in the workplace as well. You should give all workers information about the date and times of the potential exposure, where it took place, without giving personal information. That's a hard one. Like, I'll give you an example. Again, as I said, I'm an IPAC manager and director for a few facilities. And the hardest part is when you have someone who's positive for organism, but you can't get it out that this person has that. So it does become a bit of a balancing act. It's a little bit fun, but you have to find a way of getting this information to your staff without identifying the person who is ill. 9 times out of 10, people are going to figure it out. It becomes just common sense. Person's not here. I'm pretty sure it's that person that has whatever it is on that fact sheet that we're sending out to staff to look out for. So, at the end of the day, your best bet is to do it in a way where you still maintain the confidentiality of those ill employees as well. And if you're advised that one of your workers have been tested positive for reportable disease due to exposure at a workplace, you have to ensure that Workplace Safety Insurance Board knows. The Ministry of Labor is also contacted within the required time that they're to be required to be contacted, that this person may have picked up a infectious disease or reportable disease in the workplace as well. Any questions at all? Any hands up? Do anything in the chat at all by any chance, Samar?
No, nothing.
Nope. All right, perfect. So I shall continue as we get close to the end of the first part. What I'm going to do once I finish outbreak investigation session, we're just going to take a quick 5 minutes. I'll come back and then we'll get over and we'll get over into environmental cleaning and disinfecting and get that one out of the way as well. So we'll take a little 5-minute break after this and get into the environmental cleaning and disinfection session after this. Employers' workplace measures. So case management is a discretion of the public health unit and may be conducted as needed for certain cases in high-risk settings or other vulnerable populations, such as support isolations. Public health units should be specific in consideration for cases and contact management for those in First Nations, Inuit, and Métis communities, and dialogue with communities or Indigenous health service providers to support ongoing surveillance and response that allows for difference in community needs and recognize differential impacts to communities. So with that being said, if the case contact management is initiated, public health may determine the frequency of communication based on the risk assessment and available staff. Case management entails investigating and confirm if a workplace outbreak does exist. They will investigate and manage all cases of reportable diseases according to the public health units list of reportable diseases, which is the exact same list that we all use within the province of Ontario. Isolate individual testing positive. Consent is obtained from the employee before disclosing personal health information with that employer. Part of case management as well is going to be identify and isolate close contacts of the confirmed case and prioritize testing of any symptomatic individuals associated with this workplace outbreak. And again, as I said earlier on, that component or that criteria is only established if you are a confined or controlled facility, such as a congregate living setting, long-term care, long-term care here, long-term care home, and any acute settings such as hospitals as well. Contact tracing, I'm not going to get into this too much because we've been killing this for the last 3 years since we've been handling our pandemic, COVID-19 pandemic. We know that in contact tracing, it's identifying those individuals who were close are close to that person who is positive during the period of communicability. In a lot of cases, what's going to happen is these are going to be your staff members, your visitors, patrons who are within who are within a specific distance to someone that was ill with a specific reportable disease. So we take into consideration distance and time of that person's duration on that person as well. So let me give you an example. We deal with measles. Measles is highly infectious. And it comes to one of those things where when you're handling that as an outbreak, which I've done many times in hospitals in Toronto, the period communicability could be very long. So a lot of times we do contact tracing. We take people that were in that facility from the time that that person who was positive with measles was there to a few hours after they left, because the air in that room will go through some form of circulation where it's going to clean. And then what's going to happen is the virus will no longer be in the air, no longer be airborne, no longer be suspended, and that chance of being infected for that person who was measles in that waiting room is now deemed nil or zero. So because of the high infectivity, high communicability of measles, contact tracing will be from the time that person was there to sometimes 2 to 3 hours after that person has left that room as well. And a lot of times that's also depending on the health unit that you're working for, as it'll take different times based on their experiences as well. So those are going to be taken into consideration for contact tracing. You're going to get the person's name, their phone number, who they're in contact with, how long they're in contact with that person, how close were they to that person. Maybe they're married, are they household contacts? Things like that will be taken into consideration, and all that will be done with the help of public health as well. Infection prevention, workers' health and safety continued. Again, general guidance is just encourage employees to get vaccinated, try to develop strategies to minimize exposure to reportable diseases, provide staff training on required public health measures, ensure staff passively screen daily with reminders as well, provide mask-friendly environments for those who choose to wear masks. New revocation of the masking mandate, as I always say, puts a lot of us at risk within our organization. So we ask that those who have now have told their staff that masks are no longer mandatory, we still want to try to make our facilities mask friendly as well. So provide mask friendly environments for those who choose to wear a mask. Schedule frequent cleaning and disinfection of high touch items such as surfaces and washrooms. So any fomites, inanimate surfaces that are dirty would have to be cleaned frequently. So during outbreaks, again, this would be addressed with your public health investigator. We typically ask that things get cleaned at minimum twice. Again, if you're a congregate living setting and you have multiple rooms, we try to get you in there twice daily to do some form of cleaning and disinfecting during outbreaks as well. So frequency is going to be, and even the, not just duration, but the type of disinfectant that's being used may be changed. I know the facilities that I use, we use Oxivir, and during really bad outbreaks, we'll use another accelerated hydrogen peroxide disinfectant, which is a cell, but it has it in a higher concentration as well. Inform staff, clients, and customers about actions you're taking to keep everyone safe, and plan and implement protocol staff, customers, and patrons safe within your organization at all times. And again, if you ever need help with developing something like that, by all means, give me a call. I can help you along those lines as well in providing something for staff. Screening, just a quick go through. We've been talking about this over and over and over. During outbreaks, screening is a very strong component of outbreak management as well. Staff are to, I guess, not I guess, but during a respiratory outbreak will be passively screened. And in some cases, depending on the organization that you are, may even be actively screened prior to entering their facility, just to ensure that, for instance, COVID, which is usually done through RAT, you want to ensure that none of your staff are coming into the facility ill and positive for COVID, using COVID as an example. So passive screening shall ensure staff understand the importance and how to passively screen. Signs to be posted during outbreaks as reminders to passively screen as well. Supplies for staff and visitors. So during outbreaks, while we're doing passive screens, we also want to ensure that we have supplies for visitors when they come in. Um, some facilities have an area where you can document that you visited, and you check mark you're feeling fine, which somewhat is a way of actively monitoring that passive screen as well. But sometimes you also want to ensure that you have alcohol-based hand rubs at those stations. Depending, we're in outbreak, you may provide PPEs at the door. You want to ensure that the PPEs are provided and that cleaning and disinfecting wipes are provided in and around those areas, so those areas are cleaned frequently as well. Train staff on how to identify signs and symptoms. So we're in outbreak, we're dealing with a specific organism. We want to ensure that this organism, that the signs and symptoms that are indicative to this organism or indicative to this reportable disease, that staff understand you are to look for this. So if we're dealing with something like gastrointestinal, see people will come up who have been positive for shigellosis or Shigella. Okay, I'll use something else, norovirus. You're looking out for vomiting and diarrhea. And in a lot of cases, it's going to be a quick 24 hours, quick vomiting, quick diarrhea, quick upset stomach. You're not looking for anything respiratory at all. So you have to also communicate that to the staff. We're dealing with a gastrointestinal organism here. We're looking out for vomiting and diarrhea. Please look out for those signs and symptoms. Vomiting, diarrhea, maybe even a fever as well. And then rapid antigen screening, if directed by public health during initial outbreak investigations, should be provided as well. And I just give an example. I've over the years, as I've been in a lot of visits and site visits, I take photos of things. This is just an area where you can passively screen, document that you've just visited the facility. Let's just be honest with you. The screens are no longer required anymore. You can get rid of those now. In terms of the screens at all stations, those can get removed. And then in terms of just having a logbook with your name, the time you've come in, and whether or not you have symptoms. In a lot of cases, that's perfectly fine for visitors when coming into your facility. I know the homes that I take care of, for the active screen, I was very adamant. I didn't want to get rid of it, but the powers that be said, no, we want to get rid of it. So I said, okay, we can get rid of that, but can we have a station or area that visitors, contractors come in and they can sign so I know what time they've been in there? It's going to show when we do run into a situation where we get into an outbreak and it gets out of control, we can actually go back to see whether or not they're part of this outbreak, meaning that they are they're contact traced, or they could have been the initial start of the outbreak as well. So just a quick photo of a station that I took a picture of many years ago. And then control measures for outbreaks. So I didn't want to get into this too in-depthly with our group here, in that we're a mix of different healthcare facilities under the community support services agencies. A lot of times you might not see this at all, but there's certain specific control measures that are always implemented during outbreaks. Again, there's always going to be an outbreak checklist that's always going to be used. They're all different with small nuances based on based on the public health unit catchment that your facility or agency is in. But at the end of the day, they're generally the same thing in terms of establishing that case definition and understanding that this case definition has been established, determining whether or not it was gastro or respiratory that we're dealing with. And when that's done, then there's a whole plethora of other requirements that come into play, which I'm not going to get into in depthly because a lot of us might not have to worry about this at all. But think local or other stakeholders within the area, so hospitals, If you're a long-term care home, CLS, maybe other ADP programs that your residents or your clients are going to have visited would have to be updated or contacted. You'd have to establish things such as the outbreak notification number, outbreak number. Then we'd reinforce hand hygiene, PPEs within the place. We'll start cohorting staff as well, and then excluding symptomatic staff home. During outbreaks, what we like to do as well is I like to do it, and I know a lot of other facilities like doing this, is we start enhancing hand hygiene, and we provide a lot. And when I say a lot of not just screening, but we like to sit down and do a audit of all the staff to ensure people were washing their hands properly and staff are donning and doffing properly as well. Because sometimes with a lot of outbreaks, what continues to spread, it continues the duration of these outbreaks. And I'm not blaming staff, but sometimes it could be us and what we're doing. And I've seen it happen in past where staff were doffing outside of rooms, which were contaminating the outside air, which was clean, and then the outbreak would just prolong. So things like this have to be taken consideration, and we'd have to also address during outbreaks. And then there's other control measures for residents or facilities. I pulled this from Gray Bruce Health Unit. What they like to ensure is that they select appropriate additional precautions for the outbreak, which is great. So are we dealing with contact? Are we dealing with droplet? Are we dealing with airborne? So things like this would have to be taken into consideration during outbreaks. And as I said already, a lot of this if you were to be in a situation that you are in an outbreak, be respiratory, public health is here to help. I'm here to help too as well. This is my forte. This is what I love. They'll help you along in terms of what to look for. So in terms of surveillance, who are we doing surveillance on? We're advising staff to watch for symptoms of new cases. Communicating, who are we communicating with? We're communicating with our staff members. They're communicating with other outside stakeholders as well. Environmental cleaning, another major part of an outbreak. How are we cleaning? What's the frequency? What are we using? Should we increase the dilution factor of it? That would be taken into consideration. And then declaring the outbreak over will all be a group exercise where public health will come in, we'll sit down with you, and you'll go through, okay, hey, you know what? We haven't had any new cases for the last 5 or 8 days. What's going on here? You haven't had any cases in the next 5, 8 days. That's what's going on here. Okay, then you know what? The outbreak will be declared over as of today. So things like that will be addressed with public health and with you as well, and communication with you. And that is it in terms of outbreak response. Again, there are other components to this, but I didn't want to get into that too much because a lot of the healthcare providers or people that are on this call today come from that ADP background as well. And when dealing with ADPs, you're not going to get into it that in-depthly at all. Public health more than likely will say, you know what? I understand you're going through something right now. You may have an increase in numbers. Monitor it for now. And if things get out of hand, give us a call. We may send some information for you to use to help you mitigate or help you control your outbreak. But right now, they can't do it. So again, all depends on the catchment that your facility is in and whatever health department that you deal with regularly as well. And with that, guys, does anyone have any questions for me at all on this? Good afternoon, guys. I am back. I'm going to start the last part of today's session, which is community support services, cleaning and disinfection. So we're going to talk about things that housekeeping should have. And we're going to go through the process of cleaning and disinfecting properly within our agencies, which I always say is the most important thing to do to avert or to prevent an outbreak with any healthcare facility. So we're going to be talking about environmental cleaning and disinfection products review. We're going to go through label reviews, documentation, cleaning and disinfection process, equipment, audits, and process carts. So just a note, I do not recommend or endorse the use of any specific product. Again, please consult Health Canada's drug product database online inquiry regarding products licensed for use in Canada. So if you want to deem or you want to use a product that you see here, best thing to do is double check the Health Canada drug product database, online query, and then you'll be able to find that product there. But the products that I'm going to show you can be used in any healthcare facility, and they're products that I use myself in the facilities that I deal with as well. So cleaning and disinfecting, what are the difference? I always hear everyone talk, oh, I'm going to disinfect, or I'm going to clean and disinfect, or I'm going to sanitize or sterilize. I've heard that before. I'm going to sterilize. I'm like, there's no way you're sterilizing unless you have an autoclave or you're using glutaraldehyde, which I know you would not be using with your bare hands. So there is a definition for the two. Cleaning is the physical removal of organic material, examples such as blood, secretions, microorganisms. It's a physical removals physically removes rather than kills microorganisms. And it's usually just water, detergent with a little bit of mechanical action, and that's cleaning in itself. Disinfection is the inactivation of disease-producing organisms. So disinfection does not destroy bacteria spores, but it does kill the organism itself. The item or the surface must be free from visible soil or else it interferes. So for disinfection to occur properly, it's something that we always teach is that you have to remove all the organics first before you can disinfect something properly. So I always say you have to make sure you wash or clean whatever it is that you want to disinfect with water and detergent or whatever you want to use, maybe some of those wipes as a first step at cleaning the area. And once that area is clean and all those organics are removed, then you can disinfect it properly. Because if you just throw a disinfectant on top of it, it will not disinfect. The disinfectant or disinfection process will be used to kill the organics instead of disinfecting and killing the organisms that's on that inanimate surface or fomite. So this is a quick overview between cleaning and disinfection. Cleaning and disinfection products. So when you're getting a disinfecting product, things that you have to look for: one, the drug identified number or the DIN number, MPN number, which is the natural product number. Very big one, because if you have a DIN on it, you know that's Health Canada approved. Health Canada has gone through all the processes. Well, that's another political thing to go through, but they've gone through the process and determining and then making sure that that product that says cleaner and disinfectant, it's actually a cleaner and disinfectant and it actually works. Also have to make sure that's within the expiry date. Last thing you want to do is be using a disinfectant that's expired 2 or 3 years ago, because you know what that's going to mean? That disinfectant component or the chemical that's inside there is no longer there. These things do have shelf lives, and there's a reason why there's expiry dates on them too as well. You also have to understand the difference between a one-step cleaner and a two-step cleaner, or one-step cleaner and a disinfectant. What are the differences between those? We'll get into that a little bit later on too as well. You also want to understand there's a contact time, and this is a very important part of it too as well. If there's anything I'm going to say about disinfectants, it's the contact time. That's what makes it a disinfectant. So if it says that it has a 5-minute contact time, you have to please ensure that that surface, whatever you're disinfecting, has or is wet for that 5-minute contact time. That's why for a lot of reasons, when you get into healthcare, we usually recommend or highly recommend that any disinfectant that you're using within your healthcare facility or organization or agency has a contact number or contact time of 5 minutes or less. And the reason for that is we ensure that the area is properly cleaned and disinfected. With a minute contact time, which is a good example of that would be Oxivir. We know for sure if I'm wiping that down, that thing's going to remain wet for at least 1 minute. So I know it's going to be disinfected properly. If I wait 10 minutes, that's a little bit of an issue because I don't know if I can keep that area wet for the full 10 minutes or for that proper contact time that the chemical is on that surface. I can't ensure that sometimes. So that's why I usually require that if you're going to get something for a healthcare facility, 5 minutes or less. Preferably 1 minute would make it a lot easier, like the Oxivir products. And then another one, wipe or squirt format. We don't like sprays. The squirt thing isn't the best thing either. We prefer wipes. Staff that I deal with, what they have is a big bucket with Oxivir or a cell. They dip their cloth. It's already pre-concentrated, already pre-mixed already as well. They dip their rags inside of it. They wipe things down, and we know it's a 1 minute contact time. Wiping is preferable. We don't like the squirting thing too much, and we really do not like sprays. No sprays at all, because what that does is aerosolize the organisms and then puts you at other further risks as well. So for product selection, again, we got to ensure that we have a DIN number is one, is that it's approved. So if it has a DIN number, more than likely you're going to find on the Health Canada drug product database anyways, but just a little added protection. We want to review the contact time, try to get something that's 5 minutes or less. And then there's other considerations also taken to think of as well. And the biggest one is PPEs. For instance, Cavicide. Very popular amongst tattoo artists because it's a very good cleaning or very good disinfectant. It's accelerated hydrogen peroxide. Actually, no, I think it's chloride. I'd have to double check that. I have so many of them in my head, but it's a very good disinfectant. However, you got to wear PPEs when you're handling it. So you also have to ensure that things like this are taken into consideration. Do I have to wear PPEs? Is it a one-step versus two-step product? Do I just have, if I use that one wipe, does it do wipe? Does it clean and disinfect at the same time? And determine the pros and cons of each product. You know, is it too strong? Does it stain my fabrics? Does it eat does it rust my metal equipment? Those things have to take in consideration when buying a proper disinfectant for your facility. Another good thing to do, which I like to do, and I've done it for a few of our agencies, is contact your current your chemical supplier, and discuss the options. They're really good. I know that it's a business for them, and they're trying to get things sold. But a lot of times when you sit down and you discuss and you have a good rapport, you'll learn a lot from them too as well. And they'll help you in terms of determining which disinfectant would work best for you. So again, determine if the product you're considering is practical for use on site. So contact times, less than 5 minutes. Mixing is another one. I'm not the biggest proponent for mixing, but I like when there is a doser or dispensing unit that's used. Great. I like when there's a dispensing unit that's used that's properly marked, because those dispensing units can all dispense for different different disinfectants used for different areas of the home as well, or the facility. So dispensing units are great if they're done properly. Storage requirements, that has to also be taken into consideration. Some or most chemicals have to be well vented. You can't take a chemical and lock it up in a bin where it gets up to temperatures of like 60 degrees Celsius, especially with this heat now too as well. So you got to get something that you can store properly. And again, we talked about PPE requirements. Request documentations for chemical supply companies to determine if the cleaning is required. Is it a one-step or is it a two-step cleaner? Again, we talked about PPEs. Expiration date. A lot of times I find some facilities or some chemical companies, I'm going to call any names, they try to get rid of certain products. So you have to be very cognizant of what the expiry date is. You don't want them sending you products that's going to expire in a month or in a couple of weeks, because you know that you're not going to use it and it's going to be storage for like 4 to 5 months. You want to ensure that the expiry dates are much further out as well. Shelf life is a big one. Products once opened and once mixed, if diluted, what happens? Just like chlorine, when we mix bleach, if you leave that container open, by the end of the day, it's just water. So you want to ensure that whatever you're using, you want to ensure that it has a long-lasting shelf life as well. And then you also want to ensure that you're reviewing the SDS. We used to call the MSDS, Material Safety Data Sheets. SDS is now Safety Data Sheets, to determine that you're handling this product correctly. I also consult for a outside company, a large housekeeping or cleaning and disinfecting company. They clean a lot of medical offices within Toronto, and they're very popular as well. And one of the biggest things that we put a lot of emphasis on is those SDS sheets. To avoid a lot of the headaches, in some cases, we have managers or special people that go out and automatically dilute the chemicals for staff before they go out and clean. And the reason for that is SDS sheets, the chemical that you're using can be somewhat harsh. So to reduce or mitigate that risk to other staff, we have staff members that are trained to do this, and that's all they do as well, based on the SDS sheet. So you have to know what type of chemical you're using. And another big one, test strips. That's a very big one. I do a lot of audits for the government, and what's one of the things I've always noted is test strips. Sometimes those test strips aren't used. My question in a lot of audits is, how do I know that what you're using here is strong enough? And I've had people say, well, I pulled it out of the dispensing unit. It dispenses it automatically for us. Okay, I understand that, but how do you know that's not broken? Well, dispense the chemical inside it. Okay, I understand that, but how do you know that chemical, there's enough of that chemical inside that one? And then usually trying to allude to, did you use a test strip to verify that that's what it says in this bottle here is actually inside there and at that concentration as well? So a big one is always ensuring that you have test strips as well on board, and having housekeeping use those test strips regularly during the day to ensure that the disinfector dilution factor in that bucket is still strong enough in terms of parts per million. Big one. And automated dispensing or measuring cup, whichever one you use or you prefer. I prefer the automated dispenser. Life is easier, and it gets things done properly as well. In the process of training, again, health and safety considerations. I like to ensure the staff are trained on this. I do regular quarterly training for this group, the group of housekeepers that I deal with in terms of outside or external housekeeping company. And it's done quarterly at all times. So you have to ensure that staff are properly trained as well in the health and safety considerations for using the chemicals, and that they understand the type of PPEs to be worn. Most places, some nice strong rubber gloves or some gloves, maybe their masks, and their work uniform. Some places go even extra. They wear gowns, masks, face shields, gloves, rubber gloves, because they're going into rooms that are heavily soiled. So again, I like to tell a lot of people, make sure staff are trained in terms of how to use it, and what to put on when using specific chemicals as well. Create a step-by-step procedure for each area. In terms of training, I like to ensure that staff understand the importance for specific areas, because you're not going to wash the washer. You're not going to clean and disinfect the washroom the same way you're going to clean and disinfect the office. Those are two different cleans. We like to ensure that staff understand the importance and understand the process in cleaning specific areas as well. So that's a big one. Train staff how to use, mix, store, handle. Yeah, that's not a bad idea. Again, depending on the organization that you use or that you are in. Sorry, I apologize. They're going to have specific staff that deal with specific procedures when dealing with housekeeping. And again, as I stated, I have specific staff that go out and deal with dilution factors. And then in some places that I work, I have the housekeepers that understand and they're trained on how to properly dilute and provide proper chemicals for disinfecting and cleaning within the areas that they're using. So they're trained on, okay, with washrooms, this is what I'm using. With general areas, this is what I'm using. In the kitchen, this is what I'm using. That needs to be identified and taught properly as well. And there has to be an implementation of systems. So track expiration dates. I like to call it FIFO, first in, first out. Review of mixing logs, troubleshooting, and users test strips as well. So I'm just going to show you some labels here, disinfectant product labels. Review the label and follow manufacturer's instructions. So is pre-cleaning required before using? What is the contact time? What is the PPE to be used? Are PPEs required to be used to use the product? Is a rinse step required after using the product and on the surfaces? And what is the shelf life of the product? Is the product within date or is it expired? These are some of the things you're going to look at on the label. So with the CAVICIDE, as you see here, I have circled an area that shows where it talks about cleaning and disinfecting. So if you look, it'll tell you how long the contact time is for this as well. And more times than one, it's going to be 1 minute. Some disinfectants do say 5 minutes. It tells you the temperatures that is to be stored at as well in terms of room temperature. All that is right there on the label, and those are things that should be looked at and taken into consideration when providing what do you call it, disinfectants for your facility. Sorry. Any questions up to this point at all? All right. So I'm going to show you another one here. This is Preempt. It's usually a one-step cleaner. And when they say one-step cleaner, it's a cleaner and disinfectant. So there's a pre-clean and there's a pre-clean and there's a disinfectant procedure for this as well. And as you look closely, it is in it. We'll tell you the temperatures to be used as well and the contact time. I always tell people take a lot of emphasis in terms of the contact time. It tells you what it needs to be virucidal. It tells you what it needs to be a broad spectrum. So if you look at the top right-hand corner, just above that circle, it says 30 seconds. Sanitizer, maybe for a kitchen, it sanitizes in 30 seconds. If it's to be used for instruments as a pre-cleaner or be used as instruments for cleaning and disinfecting, it says 3 minutes. Use either tray or ultrasonic units, immerse instruments, and preempt RTU for 3 minutes. So it also has a 3-minute contact time as well. All that can be read on this one label. It tells you exactly what's in it too as well and gives you what the ingredients are. And we know that with this, it's accelerated hydrogen peroxide, or hydrogen peroxide is what the active ingredient is at 0.55%. And again, as I said, depending on, I talked earlier on about outbreaks. Sometimes depending on the outbreak that we have, we'll use specific disinfectants for that. A lot of times when it's those gastrointestinal outbreaks, we like to use chlorine-based or chloride-based disinfectants. It works really well. When it deal with things such as MRSA, VRE, SBL, some of the other ones as well, I like to use the Oxivir or accelerated hydrogen peroxide. So again, with this preempt, we know the active ingredient is accelerated hydrogen peroxide. We had the DIN number. As I said, contact time is 3 minutes. PPE required, it says none on there. Shelf life is 2 years, which is also on that. Any special considerations? We know it's no food grades. It does say sanitize for 30 seconds and must rinse. You got to wear gloves as cleaning blood and bodily fluids, which is a given. Pre-clean heavily soiled areas, and it's a 2-in-1 product, so it's a one-step product. So 2-in-1 meaning I can clean and I can disinfect with this one product as well. And then here we have disinfectant time, so for it to be virucidal, 3 minutes. Everything's 3 minutes. To sanitize, it's 30 seconds. All right. We're looking at this one, industries. It's Saniturge, and active ingredients on this one is benzyl alkonium, chloride, which is generally it's a quaternonium, which is a good disinfectant as well. Quats tend to be a lower level or lower spectrum disinfectant, but a very good disinfectant as well. Has a DIN number. We have a contact time, which this one is 10 minutes, so it's not the best one. I'd use something like this, and generally maybe in the office, cleaning things, supplies. Whether or not PPE is required, it does gloves and eye protection. Shelf life is you find this on the online, or supplier will provide it to you. And any special product considerations, it does say if mixing from concentrate, use your test strips to require and get dilution ratios from suppliers. So they're saying that to dilute this properly, you have to get dilution ratios from the supplier. And again, I find if you have to dilute this yourself, using your own cups, using water, it does become a little more difficult. But again, using test strips will definitely allow you to understand what the parts per million is in that bucket when you're finished diluting it yourself. And it says for sanitizers, at least 200 parts per million for it to be food grade. So it is a lower level disinfectant. And the most popular one that I see a lot, Lysol, benzyl ammonium chloride, again, can be used, does kill COVID as well, and many other organisms. I always hear people say, Dale, HIV. Like HIV is so easy to kill. HIV is one of the easiest things to kill. Hepatitis A, B, and C, no, that's another question. That's a hard one to kill. Those can live on inanimate surfaces for 72 hours. Believe it or not, Lysol can also kill most and a lot of these organisms or reportable diseases that we deal with. So Lysol's is benzyl ammonium chloride. We do have a DIN number. Contact time, a little more than 5 minutes, 6 minutes. The ones that I've seen in the past have been 10 minutes. PPE required, gloves, which is pretty much the given. Shelf life, not available online. Again, you'd have to talk to the supplier about that. And any special considerations, it says 2 ounces per gallon of warm water, not food grade. sanitize at 60 seconds and must rinse. So it says to sanitize, you can use it, just to wipe down an area to remove some of the vegetative and pathogenic organisms. This gets to that, and it does work, but you have to sanitize for at least 60 seconds for that to work. Cell 5 TB, my favorite. Virucidal, bactericidal, tuberculocidal, fungicidal, very broad spectrum. Again, it's accelerated hydrogen peroxide, 0.5%. And it is good in terms of using in healthcare. 5 minutes. I use this at one of my long-term care homes and they love it. It's by Diversity. Funny enough, I know the director for Diversity. Just met him the other day, doing something, but very good company, and they provide very good chemicals for disinfecting and cleaning as well. Another one by Excel Intervention, which is their 1 minute. It's high accelerated hydrogen peroxide, very good for wipes. I believe this is a one step. There we go, one step cleaner as well. It's right there in front of us, so we can tell that we can use this to clean and to disinfect. We see the DIN right above the 1 minute, which shows that it's Health Canada approved and it's been looked at. And we know Diversity again is the big supplier. Diversity is very big. And then review of products used on site. The reason why I have this here is I talked about the automatic dosers, and I love the way this one is done. You can see the stickers on the top. One's for general floor cleaner, that's what we use. The other one's for general purpose cleaner. The other one's for kitchen. The other one's for washrooms, which is the Oxivir, which is the lower left. And that's what I like to see. If you're gonna put an automatic dosing machine, ensure that it's well labeled. The reason I say that is I've dealt with a few long-term care homes in the past, or facilities. This is long-term care, but congregate living settings in the past that weren't the best. They're located down in Toronto, actually. And the issue that I was having in this place, and the reason why there were always an outbreak, was the housekeeping staff were just using anything that came out. And I remember one day saying to one of the housekeeping staff when I was doing my audit, I'm like, okay, so we're dealing with outbreaks. I know you guys are cleaning. What is it that you're using? And the housekeeper came in, grabbed it. Yeah, we have the automatic doser. It does everything. I'm like, okay, you do your thing. I'm watching. I'm like, okay, but you're pulling from the Sani-Surge. And I'm looking, I'm like, the Sani-Surge, that's what I use for like the floors. Why did she? Lo and behold, staff weren't properly trained, or they weren't. There was the general understanding came out. No one was trained properly. They're using different disinfectants. They were using the proper disinfectants, and that was the biggest issue in that facility. The only way to have mitigated this risk or to prevent the outbreaks would have been just some stickies on top of, and staff being trained on what to use to properly clean and disinfect the high traffic areas. And after that was dealt with, outbreak numbers declined, durations declined, and the facility was back to being a better run organization. So the slight things like that make a hell of a difference. Making disinfectants from concentrates, I'm not the biggest fan of it, but you know what, it works. A lot of people like it. And again, as I said, you have the automatic dosers, automatic dispensers, which are great. Some of the facilities I use, I have them all pre-made already. They're bought pre-made, a little bit more expensive, but it alleviates that procedure and makes things a lot easier. But if you do prefer diluting your chemicals in your products, that's perfectly fine. When diluting products from concentrates, you do have to take into consideration following the manufacturer's instructions to the T. So use, handling of it, dilution of it, and whether or not PPEs are required have to be taken into consideration. Make new solutions as often as indicated by, again, the manufacturer's instructions, because it's all based on shelf life. Every different chemicals have different shelf lives as well. Equipment needed to verify the concentration when sure we got those test strips so we can ensure that whatever's coming out that automatic dispenser and measuring cup is exactly what we want in terms of chemicals, in terms of effectiveness, parts per million that's inside those buckets. Label diluted bottles. So if we're losing bottles that aren't provided, we got to make sure the dates are on those when it was mixed, and also labeling that's inside that bottle as well. That's very important. And again, as usual, I'm saying it again, the reason I say it is check the expiry date of concentrated products as well. And then documentation. When I do the audits, I'm like, okay, you guys are doing a great job. Place is great. How do I know that room was cleaned? How do I know that room was cleaned properly? So who's doing the QA? Who's going back there and ensure that things were done properly? I've had facilities that I've worked at, and I've had infection prevention control associates that work with me, part of my team. And what we used to do is every morning, as after the housekeepers were going through the rooms or going through the areas, would have them go and use something called ATP and test whether or not it was cleaned properly. So we'll take per million came off on that swab, and that would delineate whether or not it was cleaned properly and clean effectively and efficiently as well, is what I was looking for. So it's great to have some form of documentation to ensure that those areas are cleaned and that they're cleaned properly as well. So 1-step or 2-step products have to be determined whether or not you're going to use those. Shelf life of the product has to be documented as well. High touch area surfaces, there has to be a checklist so we know those areas are done. So facility I work at, I have housekeepers and I have RCA staff. We call them RCA staff. What they do is they do high traffic areas. I have them go, and that's all they do all day is high traffic areas. And then the infection prevention control staff ensure that them and housekeeping are doing the job properly by running ATP scans and determining whether or not parts per million or whether the levels of organisms on there are low enough, meaning that it was cleaned and disinfected properly and appropriately. So some of the things that we do just to verify, and I just give you a couple sample checklists that you can use. I have a plethora of them. IPAC Canada has hundreds of them that I can send to you. I have a few that I use myself. I can get sent to you as well if need be. If you're diluting, there has to be a log for concentration. So date that it was diluted, the product concentration, if there's any corrective action, and the staff that signs off on it, and how many days are you going to be doing it? What's the shelf life? What are the concentration requirements for that? That all has to be documented as well. And doing this ensures that it's being done properly and being done correctly as well. Can everyone hear me clearly?
Yes, Dale.
Okay, perfect. Cleaning and disinfection process. So how do we do it? I guess I trained, and I was like, okay, Dale, thank you for telling me about all this stuff, the DIN stuff. Thank you for letting me know I need PPEs. Thank you for letting me know about a contract. How do I do it? Like, give me the process. What am I doing? Very not easy, but there is a system to this. So when cleaning and disinfecting surfaces, visible soil must be cleaned with soap and water first. So remember I said, for something to be disinfected properly, the area has to be cleaned first, because you can't disinfect dirt. You can't disinfect dirt. So you have to ensure that dirt's removed mechanically. And that's why some of these disinfectant wipes are 1-steps. And then you disinfect after. So always move from low to high touch areas. So low touch areas to high touch surface areas. So high touch surface areas would be your elevator buttons, or the door handles leading in and out the units, or the door handles leading in and out the rooms. Those are high touch areas or high touch surface. So you go from low to high, clean the dirty. So you'll do the room first, and then we go to the washroom. The washroom's always the dirtiest area. Rooms will always get done first. Washrooms will be done last. Clean the dirty, top to bottom. I've seen someone do this one time, everything's clean, and then clean off the top. I'm like, well, hold on. That's not making sense to me, because whatever is on the top now is not at the bottom, but you clean the bottom. So top to bottom first is what you have to do to avoid cross-contamination of surfaces, and it does work. If resident space is shared, clean all surfaces of each resident area separately. If we're dealing with CLSs here, treat privacy curtains as high touch surfaces as well. No double dipping of cloth. That's a big one. You can't take that same cloth and double dip it in that clean chemical that we originally dipped it. If that cloth has been used, that's the end of it. It goes away. It goes back into the dirty cloth. You get a new cloth after that. Compatibility with surface or finish or material, self-explanatory. Do not top up the product bottles. Clean the bottle out before refilling. That's another big one. Those bottles that you use, if you have concentrates in bottles or chemicals in bottles, don't keep on filling that bottle. Use out everything that's inside of it, clean and disinfect that bottle, make sure it's dried, and then put the cleaner or whatever chemical you want to put in after that. Top up bottles will over or under dilute the product, and that's the big reason. And as well, sometimes the bottle might end up being dirty, and you're just putting clean product now in a dirty bottle. So make sure that bottle is cleaned at all times. And rental cleaning and process. It's so funny how I have a picture of someone spraying something, and that's what you should not be doing, is spraying anything at all. No sprays at all. So assemble supplies, clean hand using alcohol-based hand rub, put on your PPEs, do your assessment. What am I doing? What am I cleaning? What am I going to need? Clean and disinfect. So clean to dirty, high to low touch surfaces, top to bottom, remembering that the bathrooms are always last. Fresh cloth for each room, no double dipping, and consider separate cloth for the washroom. So I don't even consider it. Use a separate cloth for the washroom at all times. A separate clean cloth, and that's the washroom cloth. Throw it away at the end. Disposal, separate dirty cloth from clean cloth. Replace garbage bags and remove non-hazardous garbage. Big one with that one, what I tell a lot of people is never ever put the garbage bag up onto your skin whatsoever. Never put your hands in the garbage bag to push it down. Don't stick your foot in the garbage bag to push garbage down, and don't with your head above close the bag to get the air, where the air in garbage bag now blows into your face. That's a big one. The reason for that is, and I tell the staff that I do training for the environmental services company, you don't know what's inside there. And a lot of times you're in an area where people are vulnerable, high risk, drug users. They're going to throw their syringes sometimes in the garbage bags. You don't know. You might have health staff that, listen, I call it brain farts. People have brain farts sometimes. I had a buddy of mine, he used to be a pilot, taken off one day, pull a landing gear too soon, a plane hit the ground. He said he had a brain fart. People have brain farts sometimes. It just happens. Someone could have dropped the syringe into the garbage bag, and then you're putting your hand in, you're putting your foot in. Don't ever do that. Don't close it with your face above, because you don't want what's inside there to blow in your face as well. And always remember to replenish supplies, perform your hand hygiene, and remove your PPEs and discard once you're finished your task. And then perform hand hygiene again at all times. So low touch areas, items that has minimal contact with hands, requires cleaning on a regular basis and when visibly soiled. Examples of that will always be the floors, the walls, the mirrors, and chairs. And you always want to ensure that the disinfectants that you use for the floors are only used for the floors, and not something else that you want to use for other inanimate surfaces at all. What I want to touch upon here, and that's it. And if you're going to be cleaning chairs, ensure that the chairs that are provided are impervious chairs that can be cleaned and disinfected properly. I don't like seeing cloth. You can't disinfect and clean cloth. It's very difficult. It has to be something that's soft, impervious, and well intact as well. And this is just an example of what grows on some of the surfaces, doing some ATPs. They're able to get some Staphylococcus aureus inside there. It's so funny. I used to be a microbiology tech at St. Joseph Health Science Center when I was in university, and to this day, I find it difficult to decide what's what here when you're looking at these. But yeah, these are different organisms that were on a surface. High touch areas, again, cleaning at all times, require more frequent cleaning and disinfecting. What I like during outbreaks, all rooms twice a day. Outside of outbreaks, once a day. High touch areas are always cleaned at least at bare minimum once a day, but I do have the staff in some homes where they do regular, still have housekeepers that go into the room once a day too as well. So exam beds are going to be clean, doorknobs, drawer handles, elevators, buttons, light switches, and toilet levers. Those are high touch areas, and those are the dirty areas too as well. And again, if you could tell the difference, this is a high touch surface, and the amount overgrowth of organisms is substantial when you compare it to the last one as well. This is the reason why we need to clean and disinfect those high touch surfaces regularly. And this is just a checkpoint. I just want to show you the process when I say from high to low and clean to dirty. And this is just an example. Windowsills, door lights, light switches, bed rails, washrooms always being the last place to clean. And environmental cleaning equipment. What kind of equipment do I need? Mop heads must be changed and laundered daily or when dirty, dried before storage, and do not store mop heads wet. Microfiber is what I like to see, is what I usually see, and I think is the gold standard for a lot of facilities. Microfiber mops and cloths are the go-to right now. Toilet brushes must be replaced on a regular basis, so disposable. Do not store toilet brushes wet and dedicate to resident rooms. If, again, we're dealing with CLSs here, definitely keep in the residence rooms. If it's ADP, keep it next to the toilet. Just make sure they're cleaned and try to keep those things dry too as well. Cleaning cloths have to be task specific. Replace after each resident room or every room that we do. Change when no longer saturated with solution and after cleaning heavily soiled areas. Separate clean and dirty cloths and consider color coding cloths. Example, red for washrooms, which I do, and green for bedrooms, which makes a big difference. Sponges are single use. And again, no spray bottles. We hate spray bottles. Those things aerosolize organisms very easily and aren't the best thing to use. Electrostatic misters versus foggers, not the best. The reason I don't like them is I prefer that the area be clean first before you use them. Once the area has been cleaned properly, then yes, I don't mind them. They do work. In addition to manual cleaning and disinfection, not instead of. Follow manufacturer's instructions for mist and product use, handling use contact time as well. If there's a reentry time, approved products only, and PPE requires as well. So definitely go through the SDS sheets and ensure that either medical mask or N95 mask is to be worn when dealing with these electrostatic misters or foggers as well. And again, as I said, I don't mind them. They're good. I just like to see that the room is cleaned properly prior to being used, because I find that a lot of people were getting, I shouldn't say a lot of people, a lot of organizations were getting misters, electrostatic misters, foggers, but what they're doing is just going in the room and spraying it all over the facility, all over the room. It needs to be cleaned first to get rid of any organics before you can spray the disinfectant for it to work properly. And again, mops have to be cleaned at all times, and electrostatic or microfiber mop heads are the go-to for that as well. And finally, the audits. We got to audit, as I said, QA. Review the process with staff. When, how, what, where are we cleaning? Frequency as well has to be checked. Just-in-time feedback and coaching. Just as they leave the room. I used to do ATPs. As the staff is in the room, or sorry, the housekeeper's finished, I get the IPAC associate to go in, swab everything, come back out, run it through the machine, ATP. Was it clean? Yes. Was it not? No. Okay, we got to go back in there and do another run through. It wasn't disinfected properly. That's QAing. Just-in-time feedback. Why? What did you do that wasn't correct? Maybe you didn't. Maybe the cloth you had didn't have enough chemicals on it. Maybe the contact time wasn't done. Did you test it with test strip? Is there enough? Is the concentration high enough for this? Things like that would have to be looked at and taken into consideration as well. Documentation. Frequency of audits. Facilities that I work in, we audit. Typically, they say at least 50 a month. We do 50 a day sometimes, and that's hand hygiene, that's donning and doffing, that's everything IPAC related. That's all they do. ATPs, audits, constantly being audited, and ADPs. It's a little difficult. Audits would probably have to be at the end of the day, or in some cases, you may have that person who's doing the housekeeping audit themselves as well. It's a little bit different. And again, you also can have your IPAC resource. Myself can also support you with that. If you're looking for any audit tools that you want to use, definitely let me know. From you that I use in the organization that I work at as well. So let me know if you need any audit tools to be used to audit housekeeping. Here's a sample one as well, sample room audit checklist. I believe this was taken from the PIDEC document, which I will also send to everybody. It's a document that we use. Best practices, it talks about everything relating to cleaning and disinfecting and any form of healthcare setting in the province of Ontario. Very good read. It's 166 pages, and mind you, believe it or not, I've gone through it a few times. Part of my job. Not the best read, but it answers every question you have in terms of cleaning and disinfecting. Environmental cleaning, housekeeping, cart audits. I like doing these quite frequently too as well, because sometimes you'll learn something about the housekeeping staff, whether or not everyone understands what they're to do. Clean cart checklist should have cart is cleanable, clean items stored separate from dirty items. There's always going to be an alcohol-based hand rub available on the cart. Chemicals can be locked, stored, or secured on the cart as well. SDS sheets are available. They tend to be inside the room. Labeling cleaning products, WMIS is available, and cleaning cart cleaned at the end of each day. So that cleaning cart has to be clean and pristine, and all the items have to be separated from clean to dirty. That's a big one. I like to see the two separated from each other properly, and then as well as ensuring that there's some form of ABHL, alcohol-based hand rub sanitizer on that cart. And that is it in terms of environmental cleaning and sanitation. Are there any questions for me regarding this topic, or anything regarding this or the last topic? Again, I am going to send everyone out the slide decks. You're going to get a copy of it today after our presentation. And again, I'm always available if you have any questions or any concerns. But is there any questions out there for me?